Welcome back, warriors and supporters, to another great episode of CWF Presents CRPS/RSD is Real. We are here today with Dr. Austin Harris of Neurorelief Ketamine and Infusion Therapy. And today we're going to talk about his extensive background in his study of ketamine and the different properties it has and how it can treat pain and also mood disorders. And welcome.
Thank you so much, Brittany. It's a pleasure to be here. This is obviously a topic, a field, a client population that we're both extremely passionate about, and that I'm grateful to be able to offer insights and assistance with regards to. And I think it would be wonderful for those that may not already be CRPS warriors to maybe understand the struggle that folks that have these conditions experience.
I get to meet a lot of different resources and learn about a lot of different treatments. And then my most joyful part is being able to share that with others that have this condition. I got diagnosed with CRPS in January this past year, actually. It had jumped to my left leg. I had it for a couple of years in my right hand and didn't know it. And my boyfriend also has it. So I was very familiar with the condition due to him having it full body. I was on the hunt for anybody that could relate, had been through some of the scenarios he'd been through. And it's just been really my mission to have everyone's voice be heard more than anything. A lot of the times I feel like these symptoms are so bizarre and extreme that people can't relate. An example I would think would be, it's hard for somebody, especially if they've never, say, broken a limb or anything, to associate putting your socks on with extremely painful, or taking them off, you're taking your skin off with them. And so when you're taking forever to put your socks on, it can become annoying to the people around you, right? Because they're not registering that. And it's hard to have to remind people. And it's hard because you feel like a burden. And the more you lose of yourself, it's what's taking its place is this illness. So I feel like myself and a lot of others tend to identify as this illness. And just because it's what's taking the place of the bits of us that we used to know. And that can be very isolating and debilitating, along with just the pain and trying to find something that can help. I don't personally expect pain-free, but finding something that can help is difficult. And that's why this is so important, is finding the doctors that have perfected a treatment or are doing research and trying things that are new and are willing to work with us and use kid gloves if we need them, and have faith that we can get better and give us a little bit of hope instead of slapping that untreatable, incurable stamp on us.
The label, exactly.
Yeah.
Well, thank you for sharing that background. And just to introduce myself, my name is Dr. Austin Harris. I am the owner and medical director at Neurorelief Ketamine and Infusion Therapy in Sherman, which is a suburb of Los Angeles, California. I have been administering ketamine for one purpose or another for going on over 16 years now. So before it was cool. And that first started with my career as a cardiothoracic anesthesiologist. That means that in addition to being a board certified anesthesiologist, I subspecialized in open heart surgery, heart lung transplants, major trauma. The big, long, dangerous, scary, dramatic types of procedures from the anesthesia perspective. And that background and training is actually quite a bit more diverse and in depth than what most general anesthesia requires. So ketamine was a tool that I became comfortable and familiar with because it is so safe. So you can administer that as an anesthetic regimen or a sedative in patients that are very hemodynamically compromised, like severe heart failure, or someone just is about to get a transplant, which means they're very sick. And you have to do certain procedures during or in the ORs prior to them going to sleep, because once they go to sleep, they're going to become very unstable from a blood pressure, heart rate, that sort of hemodynamic standpoint. And ketamine, as it was first invented actually by the US government in 1962 to treat field trauma in Vietnam, it is extremely safe. So it actually supports blood pressure and heart rate and spontaneous respiratory drive. So it's the perfect tool, and also not just to provide sedation safely, but it actually does increase or support heart rate, respiratory drive, et cetera, increasing the safety of that patient during the time that it's being administered. It's a incredibly unique and valuable tool, the only thing of its kind. Right? It is a category of one dissociative anesthetic. There is no other tool or molecule like it, either natural or man-made, known to mankind. This was what first sparked my interest in it, is simply because of its uniqueness. Going all the way back to med school, I was like, oh, this is really interesting. Then through training, you learn to utilize tools. And that was one that I found to be extremely useful in a lot of situations I saw more often than even other anesthesiologists, or certainly other types of doctors, including pain management doctors, neurologists, et cetera. They don't use that. That's not a part of their wheelhouse. And as that became incorporated into my own clinical practice, at first in the operating room, I started to find more and more areas where it could be utilized. And it's an older tool. So even a lot of the newer trained anesthesiologists don't reach for it very often. They have other things they know how to do better, which is totally fine. But you always want the best tool for the job, maybe not the easiest or the most common. And I remember back to, this is many years ago now, where I don't just do heart surgery as a cardiothoracic anesthesiologist, but we also do all the other types of surgery, from the simple broken leg to the appendix removal to spine surgeries, et cetera. And I had found myself, this is many years ago, in the first hospital I actually worked in outside of a training environment as a full-fledged anesthesiologist. And there was a new type of surgery that was being done that created a lot of difficulty for management of the patient, right? And that was a new kind of spine surgery where, a lot of folks, they suffer with scoliosis, right? So a curvature of the spine, it's genetic and progressive. And at one point, I think it was Medtronic, created a new system for doing these. Normally they would be staged. If there's an 11 level spinal level surgery that all that needs to be straightened, they would do 3 spinal levels, straighten, fuse it, and then the patient would go to recover from that. They would bring them back to the OR a couple of days later, do the next 3 until they had the whole spine straightened with anchors and pins and rods and things like that. And then someone decided it would probably be more cost efficient for the hospitals. And if instead of having these long hospital stays, we could do the whole surgery in one sitting. And that, I think, was the motivation, where they designed this process where they would put these anchors on each vertebral body all the way up, so all 11 levels. And then using rods and wires, they would put them through those anchors and then just like the whole spine in one sitting. It's a good thought from a technical perspective, but what about the patient? What about the facilitation of that surgery and the recovery from it? That's a significant operation to do all that in one sitting. And they were finding this extremely difficult. The hospital I was working at was very excited about being a landmark site to do this. And they brought in some surgeons that had just trained on this technique. And they were like, we're going to do this. We're going to be the best at it. No one consulted the anesthesiologists. And as they started to do these procedures, it was creating a large amount of complications because the post-op management of the patient's pain from the procedure was looking impossible. Here you have patients who usually are severely progressive in their disease because otherwise they wouldn't qualify for the insurance coverage of the procedure. And so they're extremely disabled. They're usually on multiple high-dose pain medication regimens just to exist, meaning their tolerance to pain medicine is very high. So as they would go into the surgery, we would do what we normally do. We would intubate the patient, we would turn on the inhaled gas, give opiates here and there when we saw from the vitals that was necessary. But in these patients, they were so physiologically dysregulated, right? Their heart rates and their blood pressures were always high. It looked like they were always in pain. And so we're doing the anesthesia and we would be giving large amounts of opiates just to keep up with what we were seeing physiologically on the monitors. And then at the end of the surgery, the goal is to have them wake up and take the breathing tube out, make sure that they're breathing on their own and control their pain moving forwards. That wasn't happening, right? We would try to wake them up and they had gotten so much opiates just to what we thought control their pain that they weren't breathing on their own. They had to go to the ICU. We looked bad. The surgeons were upset. The hospital was upset. What do you want us to do about it? We then tried to use less opiates, and then the clients would wake up with extreme pain. And it was very disturbing for all parties involved. No one seemed to really be wanting to look outside the box. I stepped forward and I said, we've got to do something here. I designed a basically ketamine only anesthesia protocol that we might try in these patients because we already knew ketamine has the ability to reset opioid tolerances to a lower level and simultaneously work in a different way to control pain and facilitate anesthesia. So it's a trifecta. So I'll always remember the first client we tried this on, and we, at the end of the surgery, woke her up and everything was calm. She required almost no opiates during the surgery, which was very strange. And her vitals were very stable, very calm. She woke up in the recovery room about 10 minutes later and just opened her eyes and went, hello, to the nurse that was next to her. And I was sitting there like a hawk watching this patient because I'm like, I don't know what's going to happen here. And nobody else does either. And it was shocking to say the least, especially the many patients that we'd attempted to do this operation on before. That was, to be honest, traumatizing our department. And she woke up and it wasn't just that she was pain-free, and she was. She had this huge 11-level scoliosis repair with almost no opiates and woke up breathing on her own, pain-free, and stayed pain-free. She didn't require a single opiate for, I think it was 48 hours after the procedure. This is unheard of.
Yeah.
No one had ever seen this before. And the other thing, and this is early on, right? So this is before people were really popularizing the concept, at least to the lay population, of ketamine's effect on other mood, depression, anxiety, PTSD, things like that. Pain was really its first, it was his first primary indication. And it was like a different person had woken up. When she was before the surgery, she was, to put it nicely, extremely nasty, as a lot of these folks are because they've been suffering so long. She had scared all the pre-op nurses off to one side of the pre-op bay She was almost unconsentable because they have been suffering so long. It affects all aspects of their sense of identity, as you discussed, their personality structure, their defense mechanisms, their sense of hopelessness. And the person that woke up was like some exorcism had taken place. Seriously. And it stayed that way, right? From the second she woke up, I followed her up maybe once a month for about 6 months. And that effect, as if not just the physical pain, but the emotional pain and the effects on her from a neuropsychological perspective, from what the ketamine had done, was long lasting. And this was a revelation to me personally. And I guess it speaks to where I come from in all this. I've had a very interesting life. I have a lot of childhood trauma of my own, the depression, anxiety, things like that I'm very familiar with in the past, and chronic pain. I have injuries that I linger today. And when I saw this, it was extremely personal somehow. It made such an impression in me that I became a bit obsessed, for lack
You
of a
had to
better
do
word.
something with it.
And it became something that I tried to work in from that point forwards into almost any anesthetic regimen I did as a gift to that person for whatever reason they were coming needing anesthesia. But from then we needed to, or I felt I needed to move outside of just, you shouldn't have to break your leg to have an opportunity. That shifted into the private sector outside of the hospital and eventually to where we are today. But my point in bringing all this up is this has been a journey of exploration. And I think this field of ketamine infusion therapy is very much still in that. And those that feel a personal connection to it are the ones that I think are leading that charge. And I just thought maybe sharing that story is relevant to the experience that I think a lot of your CRPS warriors and others out there with chronic pain conditions can relate to.
I agree 100%. Well, when you described when she woke up, it's like the opposite of the transformation. And instead of watching yourself disappear, it's that person's back. And it's crazy. It was like a reset, just a switch that needed flipped, and she was a whole different person. It's giving me goosebumps thinking about it still. It just,
It was a really beautiful, incredibly inspiring, almost religious experience to watch, to
moving.
be in that as it was happening. And I credit that for really being the motivation behind everything that followed.
I can imagine wanting to be able to share that, like you said, with other people that are experiencing the same thing. And I think that too is difficult with the mental part of this illness, is when people don't understand or they haven't experienced pain. There's that expression, you don't get chronic pain until you get chronic pain. And they don't understand. They just see somebody who's overreacting, somebody who's angry all the time. They don't understand how that is just how it's changing your tolerance level to things around you. And
Everything.
yes, to everything. And it's, imagine what it's like to walk through life where everything that touches you hurts you, or that hypersensitivity to everything really changes a lot of aspects in life that it's hard to understand if you don't experience it. And all those factors contributing really just make a very lost person. And
Of course, and it's our natural instinct from a psychological perspective. And I think this will lead into another aspect of our conversation, that is what is going on, right? What's causing this? What preceded it occurring? And then what transpires as it's progressing? And that is, it is a complex situation. It's certainly, I think it's understandable that when someone develops a severe and lasting chronic pain situation, that that's going to change you. And just at an instinctive level, right? When we feel that the bandwidth of our awareness is now totally occupied with our experience of pain and our body, and that stimuli that interact with our body seem to be instinctively viewed as a negative, right? As a threat, it creates an entire response such that now we're operating off of ego defense structure and not more of what human beings are normally supposed to operate in about 95% of the time. And that is that more thoughtless, connected to our environment, sort of subconscious processing, necessarily vulnerable so that we can be maximally flowing and feeling and a part of our environment. That's really what human beings were designed to operate under, more almost exclusively that model, with the occasional need to think or defend, but that should be an extreme rarity, and especially
Living in
today.
crisis mode.
And that crisis mode, I think people can understand how that can become normalized for someone who's experiencing a lot of both baseline chronic pain, and then when that baseline is exacerbated by external stimuli, they will start to isolate. That wall goes up and they retreat further and further behind it, just as an instinctive avoidance of what is perceived as threatening, painful. We become increasingly avoidant. And as that occurs, which, like I said, is an understandable instinct, it's a part of our psyche, but it becomes progressive, right? Because the more we retreat, the less we are then able to get any sense of rewarding sense of self in that relationship between whatever we are and everything else that isn't us. And so depression, anxiety, hypervigilance, emotional dysregulation, that is going to increase if that moment of avoidance becomes normalized, right? We're not able to think joy. That's not a thing. Joy can only occur as a spontaneous, usually surprising, open, thoughtless moment of felt experiencing between ourselves and something that is outside of us, something not us. It's that transference of that moment that creates the joy response. So the more we isolate, the more the joy will become removed, and it's a self-fulfilling cycle.
It's those maladaptive behaviors, I think is what they're called. And it's hard to break those because they
Absolutely.
seem like they're helping us at first, because they are. They're putting that wall, like you said, between us and what we feel like is hurting us. But as it goes on, it makes things more harmful than they were to begin with. So it's hard when certain things that don't belong there get put in your, I need this to survive part of your brain.
Yeah, that survival mode is within us for a reason, right? Going back in time, we needed to run from the lion, hunt the mammoth, fight off the attacking tribe, briefly dissociate in order to process loss, to grieve. But these were always intended to be very short-term states. And neither our mind or our body were designed to sustain that for very long. And historically, we didn't, right? Human beings, on average, experienced exponentially more severe trauma from both an emotional and a physical perspective, let's say 5,000 years ago, than we typically do in modern Western lifestyle. Now, there's always exceptions to that, but as a generalization, on average, we are far less traumatized than we would have been in terms of the amount of total trauma. And yet, the way that we're operating societally these days is as if we're constantly under threat. And through news and media and Hollywood, and you have all these very influential things that we're consuming. And I would say we're all operating at a stress level, right? That is far above the baseline that would be healthy for us. And I guess I wanted to state that because I think it's relevant in starting to understand, okay, but how did this happen? How did this one individual develop after they broke their leg? It was repaired. There's no MRI evidence of any nerve impingement. The surgery was a total success from an anatomic perspective. And then suddenly this person is developing CRPS or some other aspect of central sensitization that's maybe less specific than CRPS. But why, right? Why that person and not the other 99.9% of people who got the exact same surgery and had a normal, healthy recovery? And I have my way of explaining it, but I also wanted to maybe hand that off to you a little bit and maybe have you comment on, before I answer the question almost, what do you think, as someone who's been experiencing this, that has worked with other people who experience this, what do you notice in terms of folks who present with this, not after it starts, but if you talk to them, what was the approach that you hear about in terms of that internal external relationship, their neurohormonal state, the stress response survival mode versus baseline, everything's cool, and communion with our environment kind of mode? What have you noticed?
I think what I've noticed the most is a simple way to put it would be, what's the state of the nervous system when the injury occurs?
Right.
Is it somebody that has been living in trauma? Is it a very traumatic experience? Or for men that have it, a lot of them were law enforcement,
Mhm.
or Brian was a corrections officer. And even if for me personally, of childhood trauma through relationships in my life, I've always said it's funny. The little things make me upset, but when something is completely out of whack and huge, I'm shockingly cavalier, because that's my baseline. It always has been. I know that really does play a significant role of trauma, whether it's for an extended period of time or a short period of time, or the incident itself and surrounding circumstances. I don't think I've met anybody that hasn't had something like that yet.
Neither have I. Neither
Okay.
have I. And like I said, I've been doing this long enough to have a pretty good sample size to draw that conclusion from. And before I say what I'm going to say, I want to preface this by explaining that I think that folks with central sensitization, because they're very demanding patients for doctors to manage, because they're suffering. But I also think because the sort of establishment, okay, I'm gonna either give a drug or give a nerve block. I'm gonna do something, and I should be seeing that have the effect that we want in the patient, right? And with central pain disorders, CRPS being one of them, or I would say the probably best known one, that doesn't tend to be the case, right? The patients are trying, at the advice of doctors, many different things, and it's not working, or it's not working well enough. And I think that the established medical model, or I should say the corporate model of healthcare as it's become, is very bad at being able to manage that situation. And the patient may even get labeled or get a vibe that they're being labeled as, nothing what I'm doing as a doctor is working. You're just crazy. It's in your head. You're just, as we say in medicine, you're malingering, you're drug seeking, whatever, as a way to deflect from that provider's own insecurity and frustration that they're not being able to help. and their own ego, right? Or in the corporate model, you're costing too much to try to treat. And so we're going to put you in this other category because we don't want to have to deal with this anymore. And I think it's important that people understand, no, this is not in your head. In other words, the patient is not going, I want my leg to hurt or I want attention, right?
Right.
At the same time that we can say that this person is truly suffering, and they are, what are other factors that we can look at besides just, okay, this drug I prescribed didn't work? And how can we help that patient to go, okay, this isn't just though that you had this surgery and you now have CRPS. Like, this is not just like the surgeon's fault necessarily, or yeah, mistakes happen, but that's not the typical pattern. It's usually either what we call causalgia or CRPS type 2, like a normal thing occurred, that thing then went off the reservation in terms of that person's experience of pain. And there doesn't seem to be a reason why that's happening. Or CRPS type 1, where there isn't a causality, right? We don't know what started this. There's not even an inciting event from a physical perspective that explains why this person suddenly started having severe pain in their leg, right? There isn't even a start point to go, it started because of X, Y, or Z. So when we look at this holistically, what does that really mean? Holistic means whole person, right? Mind and body. I think it's helpful for people to understand, because it's not that they're being judged for the patterns in their life. It's just that we want to understand what that is, because if we do that, then we can address and improve things. And that's actually an empowerment for that patient. Hey, you mean I don't just have to rely on my pain management doctor that I see once every few months to adjust this prescription, but there's other ways of looking at this, and that may be a part of it. But there is the elephant in the room, right? How is our nervous system, which is both central and peripheral, how is it operating and why? And what can we do about that? And what you described is the norm for folks with CRPS. There's always a story or a period of time that involves what we call in medicine a stress response. And that doesn't just mean I have a lot going on, right? We all have a lot going on. A stress response is a medical term. It means that for whatever reason, the neuropsyche is telling our adrenal glands to release a higher, much higher level or concentration of neurostress hormones into our bloodstream. Adrenaline, norepinephrine, cortisol, and many other molecules that are maybe less commonly discussed. But these are very potent molecules. They do things. It was never supposed to be normalized or sustained at that level. If it is, which is clearly occurring these days in an almost progressive manner over the last few decades, especially, if that stress response neurohormonal state level sustained for any length of time, it is degenerative. Okay, and I don't just mean in a broad concept. Anatomically, neurologically, at the synaptic and structural level, it is degenerative. And it also does things to our processor, right? The brain, if that is sustained. And I think we want to spend a moment just to explain what those changes are. Because I understand this at a personal level, you understand this at a personal level. I think most people, if they're being honest with themselves, who are listening to this, can probably relate. If they have the insight and the humility to look at our own patterns, we can go, yeah, that actually makes sense. because it tends to always be true. So what is happening then? It doesn't necessarily matter how that became our normal. There's lots of ways, right? Family trauma, abuse, neglect, relationships, just a deep anxiety or insecurity, our approach, our personality structure, all these things are connected in how we affect ourselves in a moment by moment daily experience. And if what has become normalized, because that's what happens, right? Our nervous system was built, it wasn't born. About 10% of who we are is innate, right? We call that predisposition, genetics, but we are all still so malleable at that young age that it is about what happens next that determines a million different ways that could go from that point moving forwards. When we talk about our nervous system, let's think of it as a complex system of roads, and it pretty much is.
Yes.
Those roads were built on demand. And what does that mean? We have a system in our nervous system, a set of resources and mechanisms we call neuroplasticity. I call it the road workers. This was what built all these pathways. And how are they built? Like, how did the workers? They're just grunts. They don't have a master plan on the nuances. Why would they have reinforced one pathway versus another? Why would they put a dirt road going this way and a 5-lane highway going this way? The instructions that are given to the workers have to do with how and where the bandwidth of our awareness is invested. So is it being invested in that subconscious external flowing with a part of our environment or not so much? That's just instinct. We all have it. And during that formative build, which is mostly pre-adolescent or early adolescent, that was about 95% of when those roads were being built. The patterns that we were experiencing, most of which we don't have any control over when we're that young, are the instructions to those workers to reinforce different patterns of instinct, perspective, response patterns, emotional patterns. All this is being coded in, and that can continue, right? Just that malleability wasn't just when we were very young. That neuroplasticity, yes, it's a little less as we get older, and it levels out around 25. And then it's supposed to continue at that level for the most of our rest of our life so that we can adapt that formative build. And through our emotional maturation process of our experiences, growing and evolving and adapting to hopefully become increasingly efficient creatures. But what if that initial build reinforced to a certain degree roads or instincts that, while probably totally understandable at the times that they were being felt, right? You're a child, you don't really have the opportunity to change all the patterns around you and what that feels like. But if we, for whatever reason, have developed too much of a normalcy or a comfortability or a preferential investment pattern of being in here, in our head, apart from, that's just an instinctive response. But if it becomes ingrained, then we are set up for
Really hard times.
yes, one way, shape, or form, right? Because depression, anxiety, OCD, just on the mood side of things, that's where that comes from. And when you add in the physical, this is controlling the physical. It's controlling the neurohormonal state. And it turns out, and we actually figured this out from ketamine over the last 15-ish years, that malleability that we were supposed to have so that we could go back as we got older and adjust these roads so that they were more adaptive and effective for us, we can lose it. And it's quite ironic how that occurs. It turns out that stress response to neurohormonal level at a receptor level in the brain turns off neuroplasticity. So the very workforce we would need, even if we had the best therapist and psychiatrist and pain management doctor and neurologist and life coach and new support system and willingness, motivation, time, bandwidth, and courage to try to invest our awareness differently and build something new, the very workforce that would actually do that at an infrastructural level has been on strike the entire time.
Yeah.
And it doesn't come back until the stress response fully de-escalates, which it's not going to, because nothing's really changing. Nothing really changes. This is the setup it looks like if you look at the numbers and the individual, and someone actually takes the time to get to know someone, get to know a patient, you always see. And it's very unfortunate, but it does create a hypersensitized processing, right? Such that in three major ways. Number one, when you've lost the neuroplasticity, we can't really change much. Number two, we have totally normalized at an instinctive level that in here is who we are. It's a very internal sense of self, not an interactive or more of a communion with our environmental stimuli and the people, places, things, objects, living and unliving situations and experiences of daily life. This is what has become normalized to feel comfortable, safe.
Referring to.
Right. Then the vulnerability of the interactive state, the inner-outer relationship. Our tendency to focus all of our awareness inside us, which I would say is our body as well, is normal to us. That's our go-to move. Especially if there's causalgia, right? You have an injury, you're in pain, and the full on that occurrence or that experience is now become our entire identity, right? And it can happen very quickly. It's just like every ounce of our suppressed emotional pain over a lifetime, the resentment of what we've missed out on, our fear, our anxiety, our insecurity, everything now becomes channeled in such an angsty, resentful, fearful way onto one little area of our body. And there's something I say, I don't know if it's commonly said, but the way our nervous system operates is basically where we focus, we will feel.
Yeah, I understand that concept. When you distract yourself, sometimes you can forget about it, or at least it's not as intense. Focusing on it, it just starts.
It will magnify. And that's the way our brain is supposed to work. I use the word bandwidth intentionally. It denotes a limited resource, right? So where it's invested, it's not going to be invested somewhere else. That's evolutionary, right? So that you could prioritize certain stimuli over others so that there's intent to our awareness.
Right.
Which is fine when you need to make sure that the lion looking at you over the stream has priority over the pretty flower on the grass at your feet. But it depends how we use it. If we're very internally preferential in thinking, and this is me, this is this bubble here, and it doesn't necessarily involve, or maybe preferentially doesn't really involve feeling affected at an emotional level by that which is not in our control, right? Sort of creates this illusion of internal control and safety. That's what our ego defense structure does. Here suddenly is an occurrence where something has affected us and it's a negative effect, and it just, every ounce of our being is now like in full trauma response, all in on that thing. And when you already have the setup for a sort of a hypersensitized or a larger than proportionally might be helpful for us investment of bandwidth internally pattern, that's what we see in folks that seem to develop CRPS. And it's not on purpose, right? They have no control over that, none. And it's not their fault at all. And I think it's important that they understand that, right? This was an instinctive response. The other big thing is that sustained neurohormonal stress state seems to hypersensitize certain processing areas of our brain. We talk about an area of the brain a lot called the default mode network. Think of it as a clearinghouse, right? It's the checkpoint that all of the neurologic data from our whole body is coming through, and it decides, okay, 99.999% of the normal neurologic data of our body is not necessary to rise to the level of our awareness, because that would be distracting. So it's almost all supposed to be filtered out. That tendency to de-escalate neurologic data, we can see a switch kind of get flipped, right? Instead of deprioritizing physical data, it goes the other direction. It takes data that is not needed, like CRPS type 1. In other words, our foot's not in the fire, right? It never was. And yet the processor is experiencing it as if it was. Why? Because instead of deprioritizing that signal, it is over prioritizing it. The chronic stress response states that preempted or preceded the pain situation seem to set the stage for that switch to get flipped.
Set it all up for it.
Mm-hmm.
I completely understand. You just explained to me what I haven't been able to figure out for a long time, even just when you try so hard to get better and you don't get better. And for me, it was with my mental illness to start, that I would try so hard, all these different therapies and different therapists, and it was just who I was, is what I identified it as, like you said. And it was just me, and I wasn't going to get any better. And that was just how it was. And I found a lot of irony being diagnosed with the CRPS when it's described somewhat like my mental illness, is being on fire and being hypersensitive to the slightest touch. And it's just a reaction. It's almost, for me, it was always, I always likened it to, if you've ever seen the movie A Perfect Storm.
Mm-hmm.
In the end, with the storm and it's at its worst, you can't get your head above water long enough to even take a breath. And at that point, your cognitive function is not there. You can't make choices, you can't filter information, you're reacting. And
Right.
it's really survival mode, because everything is just so loud and so overwhelming that it's, as uncomfortable as it is, I had to learn how to have to sit with myself and ironically ride the wave until it subsided. And it's hard, like a flare, to ride the wave and to know you have to until it's ready to be done, and it's going to come back. And I think that's really hard. And I think that the first flare that you get It's scary because it's huge, it's painful, it's right now. Sometimes you don't know, like you said, there's no documented injury. For me, I woke up with the flare spread into my foot. And I had an idea of what it was, so I just acted accordingly. But it's hard and it's scary when you don't know what's going on. It's that extreme, and then nobody can tell you.
Of
And
course.
and that fear then keeps you in that state. It's that cycle, like you were talking about, that it's just that state of unknown, scary unknown. And I think that's just the hardest thing is not knowing at the beginning. And then I've heard a couple of people say that when they find out, sorry, dude, when they find out that they have CRPS and it's not really explained thoroughly or correctly to them, that they're almost not relieved. They wish they would have, they wish they were still back in that point where they didn't know. And we all can't be good at everything. I feel bad for people that it's not their area of expertise. They can't be expected to explain something that's not something that they practice every day or that they really know extensively, but at the same time, it still significantly affects the patient, especially if it's the fifth doctor maybe this month that can't tell you or can't explain it to you. And just by talking to you, I've learned more and things, the contributing factors around everything and how they all tie together, just the mental and physical aspects of how important that treating that combination really is in this case, especially. So,
Well, I appreciate you sharing that, Brittany. And based on my experience and yours, now that you're working with other people who share similar stories, it does give us insight into these patterns, and it's easier for us to understand because we're seeing it, we're involved in it. But the individual who doesn't come from that background, as you described, is just in pain and they don't know why. And the way healthcare is set up right now, it's so compartmentalized that the process by which, if they are even able to get a diagnosis, get an answer, and let's be clear, CRPS is especially type 1, is what we call a diagnosis of exclusion. Right? In other words, they've tried to find every other possible diagnosis, and when they can't, it's CRPS.
right.
And then they start thinking about, all right, was there some sort of confirmatory aspect that we can, or tests or things like that, that we can look to hang the hat on? Meanwhile, that patient is just suffering and confused and scared and frustrated because no one can give them clear answers. And speaking from experience, this is actually the typical state that we normally see most of our patients, right? They've either don't know what's going on yet, and no one will give them clear answers, even a CRPS diagnosis, or they just got the diagnosis and they've done a little bit of work, or the doctor that gave it to them is, here's your diagnosis, but there's nothing I can do about it. Or the third category is they've had the diagnosis for a while and a doctor, or in many cases, many doctors, have been trying many different things and nothing's working. And with each attempted therapeutic that isn't successful, that patient is becoming increasingly hopeless and scared and depressed and anxious and traumatized just from that process. And one of those states is typically where we see people at Neurorelief, right? That's where they start going, okay, I feel like I've either tried everything or no one's talking to me, so I'm going to try to do some of my own research and explore what might be outside the fact that I have the monthly appointment with my doctor who isn't telling me anything or can't help me. That's usually where they come across us. And maybe this is a good segue into what does that look like? And maybe we can just talk first about what is ketamine? How does that work? Why are we using it for this situation?
Okay.
Although it's not exclusive to this situation by any means. And in a brief, easily consumed explanation of, okay, it's doing these things. And then even beyond that, it's still just a tool, right? It's a tool. What are we going to do with it? And how that tool is utilized by those that are wielding it is super important. What can a client do as this tool is being provided to them
Right.
to optimize the benefit, the healing, and the outcomes that is why we're doing this, right? So there's a couple different very connective areas that we want to address when we're answering those questions.
Okay.
The first one is, okay, what the heck is ketamine? We introduced that briefly, but how does it work? And it is a dissociative anesthetic, but it's far more complicated in what's going on once we have ketamine in our bloodstream. Most medications that we're aware of act on one receptor, right? It's okay, there's a dopamine or an acetylcholine or a nicotinamide receptor. And it's okay, that's where that molecule is going to bind to, and it's going to have that effect. And mostly that is the relationship. Ketamine acts on 7 different unique receptor types at the same time. That is unheard of. It's the only molecule known to mankind that has that diverse a number of potential actions or effects.
So it can help pain and the mental component.
And it's doing both of those from multiple directions.
Mhm.
Right? It's not like just this one receptor is helping pain, this one receptor is helping depression, right? It's affecting all of them at the same time, meaning that in that individual, it's walking and chewing gum. And it is a holistic, both experience as well as effect, right? We are getting peripheral nervous system, noticeable physical sensory changes. We are getting a central nervous system in terms of our psychology. We talk about NMDA receptors and GABA receptors and things like that. We are also getting, so that would be like the neuropsych. And then there's the pure psychology, in other words, experiential, right? The ketamine itself has the ability, done properly, to create a very specific psychological state we call ego disillusionment. It is a psychedelic at these lower doses, and the doses we use are much lower, especially starting out, than you would use in like a general anesthesia situation. At these lower doses, it's a psychedelic. Now, people think psychedelic and they're like, oh, you mean like LSD or mushrooms or something like that? Yes and no. It does create a sensory dissociative experience, but different, right? It is able to turn off temporarily at a neurologic level the very part of ourself that we call the ego. It's the thinking thing, it's the protector, defender, survival mode, all that. It creates the anxiety, either to disincentivize us from doing something or motivate us to do something. But it is that sort of that is where the impetus or the push is coming from that creates the stress response.
Right.
Right. And then sometimes that's necessary, but not at baseline.
Right.
The ketamine, when we're doing it right, we're actually achieving this very unique state. And I describe it this way. You can take large amounts of magic mushrooms, LSD, ayahuasca, bufo, 5-MeO, DMT, ibogaine, peyote, mescaline. There are about 300 different entheogenic or psychedelic molecules, both natural and man-made. All of them are in one category, and ketamine's in another, which for ketamine is pretty typical. It likes to be in a category by itself.
Like,
It is. It's fascinatingly that way. But in ego disillusionment, imagine it like this. This is the range of your defense mechanisms to bother you, to be like, hey, something's wrong. We need to retreat back into ourselves for safety and protection. In, let's say, even taking very large doses of psilocybin mushrooms, you're still here, right? You're having a very dissociative experience, but you're not out of range of your own defense mechanisms.
that
Okay,
makes
so the ego's still in the room, meaning there may be some therapeutic value to these molecules, but it's just, in my opinion, we're not at a point of understanding that makes it a go-to clinical maneuver. After all, it took 60 years for ketamine, and that's when it was legal. Psilocybin's still not legal in, I don't think, most any state. The research has been limited. Maybe someday, but with ketamine, we have thousands of double-blind, placebo-controlled, peer-reviewed studies, trials, and case reports looking at how would we use this molecule different ways in a way that's going to help the most number of people for different things and be able to modulate the implementation differently for different people.
right.
Takes a long time.
Yeah.
So back to the metaphor. In psilocybin, you could end up in a situation where you're experiencing a lot of emotional permeability, right? The wall isn't as rigid. And that's a typical psychedelic experience property, right? You feel suppressed emotions, they're processing out, which is in the long run a good thing. But in the short run, if our defense mechanisms are still able to go, hey, I'm not sure that's what we do. I need to be back in my illusion of hypervigilant control to feel safe. And that's not possible because the half-life of the molecules range from 6 to 14 hours, depending on which one. So you're pot committed, right? And you
Yeah.
can experience a lot of cognitive dissonance, right? You're far over reinforced ego defense structure says, I got to be back in control right now. And the molecule's going, yeah, that's not going to happen for the next 6 hours. So that can be very uncomfortable. And that's what people call a bad trip. That cannot happen with ketamine infusions that are being adjusted to ego disillusionment. Right?
Right.
Because in ketamine, you're actually outside the range of your defense mechanisms to bother you. So it's not like you're over here watching the movie over there. We are just a part of the everything. It's a pure subconscious state because the ego's been turned off. And the subconscious is our everything. It's our infinitely wise processing system, best friend that we ever had. It is our emotional guidance as well as our emotional resolution system. But it's a vulnerable system that you don't have that illusion of control, right? You feel, and that's how it's working. You're feeling it working. In folks that have developed a baseline system of roads, it's, no, I can't trust that. And usually, historically, for good reason. In the present, it's usually just proportionate to current stimuli.
Right.
But it's still, no, I can't allow myself to feel what I feel. I can't trust myself to allow myself to feel affected by things I don't control or have the illusion of control.
Right. It's an extra weakness almost.
And it's unfortunate because that is our everything. And it's the mode that human beings not too long ago were in 95% of the time. Even with all that trauma,
Wow.
they would experience the trauma, and then as soon as it was done, they would de-escalate it together as a tribe, as a community. They would come together, drop everything, dance, cry, scream, eat, burn fires, and they would do it the same way every time, all together out in the open, to click over from ego, defense, survive, suppress, and override mode into subconscious release, clearing the slate instead of just having it build up. And they did this every time. We don't know how to do that anymore. And so
Right.
that subconscious state, even in the best of times, just hasn't been prioritized. And in the ketamine experience, we get an opportunity to feel that, to commune with our best friend, our like near divine sort of guide. It is just absolutely ununderstandable how that occurred, that we have that. We were born with it. And it is our inner healer. Every older culture talked about that. And a lot of their culture was built around that because it's the greatest gift we were born with that we don't trust or use enough. In a
Right.
ketamine experience, we feel safely released from the walls of our overly isolated experience of self. It's like just being teleported over the side of the wall. And we can't do that for ourselves. And the metaphor that I use is usually we're outside the wall, we're outside the range of the guards on the parapets. And we realize experientially, because that's how we learn, right? We're experiential, not cognitive learners. And we experience, oh, wait, there's no monsters and dragons out here. There's no attacking army anymore. Weird. I had assumed I was operating as if there always has been, but no, now I don't feel it. It just feels like endless rolling hills of green grass and wildflowers and cows and blue sky as far as the eye can see. What has it always been that way in the big picture? Huh.
Is there anything other than ketamine that can trigger that?
Not
I mean,
that. Not
that's
that.
amazing.
Yeah. And like I said, you can have some wildly dissociative experiences on other molecules, but you're not able to fully turn off that ego defensive response. You can't expect that to be a sustained, consistent theme throughout an entire experience of, in the case of the protocol that is standard of care for treating CRPS, it's a 4-hour infusion. Okay. And I'll get to the technical side maybe a little bit later, but what is occurring in that experience is deep and profound. It is a paradigm shift. In other words, new data has now come into our awareness experientially that completely changes our instincts, our response relationships back in the real world, right? Back in the here and now, all of a sudden we now have this pin dropped on our personal experiential map that we could not have had before because those walls were so reinforced. We can't really know for sure what's it feels like on the other side.
Right.
And it's the shift that we were able to experience is innate. It's automatic. It's, oh, you mean love, self-worth, a sense of oneness and enoughness with our life, our world, our environment, of value, of connection. You mean that doesn't come from trying to get it all figured out, analyzed, judged, ruminated in my own head?
I think
You
just
mean
Me,
It comes from realizing I don't need to.
that has
And
to be an incredible feeling to be able to
that's a
get.
realization we couldn't come to on our own, right? We don't have the ability to do that. None of us. And then when you repeat that, and in the proper protocol, you're looking at 5 to 10 consecutive weekdays of infusions. And what you're doing is you're reinforcing that paradigm, right? Simultaneously, you're giving your subconscious, which is our janitorial system, the opportunity to go into all the closets that we've shoved all the toys and clothes and shut the door, pretending that we're fine and just put it out of mind. All the emotional conflicts, probably going back to when we were young, including our experience of this pain situation, right? It's all down there, it's all shoved down and spilling out. And then our subconscious has unrestricted access to go in and reorganize all that and take what we don't need anymore safely out the back door, helping us feel lighter, less dysregulated, less pressurized, less volatile, and then really recovering a sense of capability of the bandwidth, being able to say, hey, maybe I can try to invest this in other places and explore what that might feel like. So that's the psychological side. And then on the pure neurologic side, it does have the ability to, through all these other receptors, target and reset the way we experience physical data, right? So that
Right.
default mode network, right? It can reset it like a circuit breaker, right? So it is now de-escalating the prioritization of data that's coming through it again, like it was supposed to.
Right.
And that becomes progressive. So, like, as someone feels less pain, that is my whole existence, this is the only reality that is, then they feel more bandwidth and capability to go, maybe I'm also my feeling of this sunbeam or the palm tree that I'm resonating with, or a hug from my child or something else. And then, oh, wait, that actually felt good. Let's do more of that. And now, instead of cycling down the drain, you start cycling back up the other direction. And that becomes progressive. It's a shift of momentum. That's what we're trying to accomplish in these interventional programs.
It's that motivation now to find this new person. I've noticed that even for me, when I can't achieve something the way that I used to be able to do it, it's that I just can't do it anymore. And I have to think about it. Can you not do it, or do you have to go a different route to get there? Is it still achievable? And this is what I think is so hard is that a lot of warriors get stuck in this spot where they don't even want to do that. And this sounds like it would be motivating instead of continuously just sitting in that agony of this is me and this is what it always will be.
Mm-hmm.
It puts you on the up spiral to be able to want to discover that person and make progress and do what you can still do. And I think that's just really hard for people to find and maybe impossible, like you said. And this is just that nudge that became stumbled upon and is just miraculous. I'm really enjoying this because I've never heard this much about ketamine in this way. And it's just amazing what it can do and the uniqueness of it as well. Like you said, likes to be unique.
It absolutely does. And I think in 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 aligning with that, it also needs to be used unique because the ketamine is a great tool, but if we really want to help someone to get sustainable long-term benefit, the goal should be not just to give someone a fish, feed them for a day, right? And so how do you do that? How do you go about retraining not just our nerves, but our whole concept of awareness and how we invest that awareness to determine what it is we're feeling and experiencing. That is the name of the game. And if we're not going to address that underlying fundamental, then you're not going to get some sort of long-term sustainable change, right? Once a groove has been dug and ingrained, you have to respect that, right? Our nervous system was designed to not change easily, right? Normally that's a good thing. You wouldn't want an experience or a neurologic paradigm to shift wildly with every new crossbreed. That would be an experience we would not enjoy. It would be chaos. However, if there is a maladaptive pattern that has become ingrained and instinctive, we have to respect that we will need to overcome that inherent resistance to achieve a sustainable change. So how do we do that? And maybe now would be a good time to explain what our approach is at Neurorelief, because it's extremely different. It is also unique. As far as I'm aware, it's the only program of its kind in the world. The first thing is how we do the ketamine. 9 times out of 10, most places that would offer a ketamine infusion, it's the same volume model, sort of drive-through operation of corporate medicine, right? Underdosed, set it and forget it, have a nice life.
Right.
Here's a little ketamine. Now we're going to bill you. Good luck to you. Next. And that makes more money, right? But it doesn't get optimal results or anywhere really close to it. If we're really going to help someone, we have got to address that situation and that whole person as an individual. We need to work with them to find the alignment to help, on the one hand, educate, listen, and find that, okay, we're on the same page, right? Now what we're going to do together. It's a collaboration, or as we say, a therapeutic alliance. Now, for me, that's the beautiful thing. I could be back and more making a lot more money. I choose to do this because it's a part of my own journey of healing and growth. And in honor of that, the time and the bandwidth that we invest with every single one of our clients here doesn't exist, as far as I'm aware of, in any other location, simply because that's the underlying ethos. That's the motivation to share in someone's journey of results. Now, what are we going to do with this one person to make sure that we're going to be able to get everything we can for that person? And how are we going to help that person to also start doing things for themselves that are going to empower that journey of healing and improvement? Because it's a collaboration. We have to do both.
Right.
The
So
ketamine
that
can
narrative
induce.
we've told and been telling ourselves our whole life.
Absolutely, that's part of it. And there's also the practical. Okay, you're telling me that I've got to do something else besides what I normally do, is just sit in my bubble in my head and focus on my pain. Okay, but how? Like, what do I do instead? What is the other pattern that you're referring to? Because I don't know what it is, right? We only know what we know that we've experienced. Someone can tell you, hey, Brittany, just be present. And you're just like, go away. I know what English means, but I don't actually understand from a practical, functional, I don't know how to do that to my advantage. So how do I learn that? So the ketamine, in addition to pain relief, resetting of central sensitization, subconscious emotional processing, resolution, and cleansing, also at a receptor level will turn neuroplasticity back on again. Okay, so the strike is over and the workers are wandering back on the road system again, and the trucks of asphalt are filled and fueled and ready to be directed. Everyone's getting paid, everyone's got their Mountain Dew again. But the question still remains, what are we going to tell them to build?
Right.
How are we as the individual, as the client, going to give them the directions that we don't know how to give?
Exactly. And this would
So
make it each of these different as well and unique to
100%.
each person and each person's journey.
Over the many years and a lot of my own learning and trying things both for myself and for others, the three things that we're doing in order to help the client do for themselves, and it's not complex doing, right? It's simply where we focus, we feel. It's a mindful underpinning. In other words, we're using mindful cognitive behavioral exercise, a very specific, trained, guided, and supported mindfulness meditation program, certified integration and recovery coaching, hour-long sessions over Zoom, one-on-one with a personal coach with background in certain specific techniques like somatosensory experiencing modalities. All of this serves as a, here, try this. And then the clients just, all they have to do is literally like paint by numbers. There's there's no grand understanding that needs to take place. There's no analysis, figuring, judgment, or struggle in comprehension. It's simply like literally put one foot in front of the other. It's just, all you got to do is follow directions. And just by engaging our awareness in these very specific patterns, it is telling our returning workers very specific directions. Build here, not here or here, but right there. They will follow directions because finally they're back to actually receive them and do something about it. In addition to all the other aspects of the ketamine experience that are beneficial, that implementation, the support and guidance in order to help that person develop the insight and the comfortability and the motivation and the guidance and the support in order to just do those things. And they're non-complicated things, right? They're very simple and very effective. Every single one of our clients at Neurorelief has my personal cell phone number, and I'm reachable 7 days a week in real time as a guide and a support system through this powerful and potentially transformational journey of healing and growth. And I have found that's what it takes to really tailor and dial in and customize and support unique individuals with what they need to be successful. And when you're combining all of this together, we have an 80% success rate. And what does success mean? There's a definition. Medical success is defined as a 50% or greater improvement in baseline symptom scoring. Nobody else is keeping track because they don't want you to know that you're not getting a full success. But with us, we utilize independent, HIPAA-secured outcome metrics with NIH-approved research assessments. It's not what you're paying 1 to 10, right? That's not real data. It's an objective collection process coming from the patients, but in a tangential, abstract way that is very valid in terms of this is what you would do if you were studying chronic pain and you were trying a drug or a device. You would need to do these assessments. So we're doing that before, every couple days, during, and after, and seeing what's working. What are we doing? What is the client doing? And it's Only after that's done that we're looking at, okay, where did we end up? And so what that means is 80% of our clients are experiencing at least a 50% improvement from baseline symptom scoring. 50% improvement is life altering.
Right.
And that is just the minimum. If someone gets a 49% improvement in a pain and disability assessment, I don't count that as a success, even though that probably was life altering for them.
Now that you've explained all of that, how does that look if I were to come into your office as a CRPS patient? How does that all play out?
Perfect question. So, first, let's talk about how the ketamine works. A CRPS patient, we actually offer different duration infusions for pain syndromes, certain neuropathies, rheumatoid arthritis, ulcerative colitis, Crohn's disease. There's a host of different conditions that we're able to treat with this, and we don't use the same protocol for everyone. Absolutely not. It should be specific to the individual. For pain situations, we have two different protocols. We have what's called the 2-hour protocol and the 4-hour or Schwartzman protocol. The 2-hour protocol is non-central sensitization types of pain. But for central sensitization, there is an evidence-based protocol that was first popularized by Dr. Schwartzman out of Yale and should be standard of care for these situations. And that is 5 to 10 consecutive weekdays of 4-hour ketamine infusions each. So Monday through Friday, then they take a break, they integrate for the weekend, and potentially Monday through Friday of the following week. Each one of these, the dose is going to be progressively escalated because tolerance, our body's ability to break down ketamine, actually occurs very quickly. So we have to always stay ahead of that to achieve optimal therapeutic value. And there's a very good correlation between dose and benefit. Now, almost nowhere are they either comfortable or able to provide the doses that are really necessary to achieve optimal results. But that's what we do at Neurorelief. So that's from the clinical perspective on timing of the infusions. Now, it's also important to understand how we give the infusions. It's done through an IV with a special anesthesia pump or machine that is delivering that ketamine infusion. Now, even in places, let's just say for the sake of argument, that they were giving a 4-hour infusion, right? How is that being done? They decide in advance, usually underdosed, okay, we're going to give 0.5 milligrams per kilogram per hour. Dial it into the pump, hit start, and walk away for 4 hours. Come back. Good job. Next.
Right.
The right way to do it is what we call real-time titration or adjustment. That means that moment by moment during the actual infusion, we are adjusting the dose delivery rate, i.e., what the patient is experiencing, the depth of experience, to dial it in real time to their specific neurology, psychology, personality, and defense mechanisms, physiology, metabolic tolerance levels. All of these factors vary widely in the general population. We're adjusting moment by moment to certain clinical, therapeutic, and experiential endpoints so that we're guaranteeing that client is getting everything they need and should get, even from the experiential side, which, as we talked about psychologically, is very important. And not the least of which is while they're in a very deep, transcendent experience, they're not unconscious, they're not under anesthesia. They're still able to respond to basic questions like, you're doing great, Brittany. Are you in a good place? Yes. Would you like to go a little deeper? Yes. Boop, boop, boop. And we're adjusting in real time to bob and weave with that client, that moment, that day to optimize the effect of what we're doing. Obviously, that takes a lot of attention to detail, which is why doing it that way is not what everybody else does, because it's very difficult to scale or volumize a practice or business model that way, but it's the right way to do it. The other incredible thing about ketamine is, in addition to be able to achieve, done correctly, that state of ego disillusionment that we're aiming for, that's a therapeutic goal, we're also able to understand that the half-life of the ketamine molecule given IV at the receptor level is not hours like psilocybin, it's seconds. Meaning that the adjustments that we're making are experienced by the client instantly. So there's this incredible precision where you really can dial in and optimize and adapt to that client moment by moment to guarantee things. And for me, that's what makes it wonderful, right? Because it's artful. Each moment is a unique opportunity to analyze and adjust and flow with that person's experience. Okay.
I was curious of if you get a lot of people that have tried this elsewhere.
All the time. And I'll always ask for their records from wherever they came from. And it's not that complicated when you know what you're looking at to go, okay, I see what was done before, and I know what we are going to be able to do significantly better. And they do experience significantly improved results.
That's nice to hear, because I feel it hurts to see people that get treatments and they think that they're unsuccessful, when it's not necessarily that the treatment's unsuccessful, it's just how it is administered. So
That's right. That's right. And it's one of the things that I'm very passionate about, because we want to see this tool become far more normalized, because it really is the only evidence-based therapeutic option for people with CRPS. And that is not limited to one little area on the body. If it's just their left foot, the other thing that could be done would be a spinal cord stimulator. But that's an invasive thing in your spine that you wear underneath your skin, right? It's certainly not something that is ideal. Whereas you have something like ketamine that really has no major downside, right? It's extremely safe. To my knowledge, there's not a single person in 60 years that has been significantly harmed when the correct dosages and from ketamine itself, right? You hear some horror story of, some movie star overdosing on X, Y, or Z, but when you look at the details, you find out, oh, so they were on 3 different benzodiazepines, a high dose opiate, and they were doing 10 times the therapeutic amount in their hot tub by themselves, right? And they pass out and they drown, right? That's not the ketamine, right?
right,
That's
right.
really bad decisions. Just done this way, like, this really cannot hurt folks, not neurologically, psychologically, or physically. We just don't see any of that, and haven't in 60 years. So it really, there's really only upside and no major downside besides time and money. But given other options, like a spinal cord stimulator, it should be the go-to move before you even try that.
Right, right.
And even the spinal cord stimulator would only be effective if it was isolated to one small area. But for folks which is not uncommon, they have CRPS symptoms in multiple areas of the body, especially above the lower extremities. There's no place to put that stimulator that is going to cover those areas.
Yep.
So
I've
then it
worked
is the only evidence-based approach to getting significant results. You were going to ask, what is the timeline? How does this play out? The first thing that occurs is someone calls us, okay? And they have a detailed phone consultation with our intake team and often myself. In these situations, I will get on the phone personally and probably do an hour-long phone call to understand, as we've been discussing, the whole person best I can in a sitting, and to be able to be a resource for that individual, whether they choose to come work with us or not. It's always a blessing to love what you do and to be able to share that with someone else, even if it's just information. Let's say someone says, okay, this sounds right to me. They will then be sent out a detailed intake process online to further elucidate all these different factors so we can hit the ground running with them as an individual, not as someone who weighs 60 kilograms.
Right.
They will then meet with their integration and somatosensory experiencing coach for preparation and a setting of intentions. Then they will come into the clinic for the first time. I will meet with them for about an hour and a half or 2 hours, one-on-one. We're going to go again into depth on what are the patterns that are present, listening to them tell their story so I can absorb that and try to learn how can I be the best guide and support system for that individual.
Right.
And that approach is something that's always adapting moment by moment through the program. It's not something we just decide up front and then play out some sort of algorithm.
It's not a one size fits every patient.
We actually, I think it's on our website, we say it's one size fits one.
Yeah.
And after that intake, we're also in that intake going to be introducing, training, and onboarding some of these other tools that the client's going to be using in their own reprogramming process, like the mindful CBT exercise, the mindful meditation program, etc. That person is empowered and also has a really solid foundation. So as they go through this powerful process, they have that to relate to, right? That we're aligning myself, their coach, the patient under, okay, what are we doing here? How does this work? And then how are we going to work together to modulate and adapt this process to you, with you, as you're progressing through it?
Right.
After that intake consult, they're going to go to another area of the clinic and they're going to receive their first infusion. And everything about that will be customized. The next morning, they're going to have their second integration with their coach before they come into the clinic. So we bookend that first experience with 2 integration sessions. We're nurturing the beginning of what is a powerful process, and a lot of emotional processing, as we've discussed, is inherent in the program. And then each morning, either every day or every other day, they're going to be getting an integration session with their coach, then coming in for their 4-hour infusion, recovery, and going home to resonate, to bask in just flowing with the processing of their experience, embracing that, and then giving their bandwidth to these strategies, these tools, these exercises or meditation that is teaching us how to focus and feel differently. And that is now going to be coded in as actual infrastructure and instinct.
You're implementing
from the beginning.
Yep.
And continuously throughout the process. And that will continue whether we're doing this as a 1-week or 2-week program. There's schools of thought in both areas. It really depends on the client's ability. More is better, but maybe not absolutely necessary sometimes. And so that's always a discussion that's going to be had with the client before, during, and at all interviews as to where they're at and what they are comfortable with experientially, symptom-wise, financially, etc. Okay.
Okay.
And that will continue. And then even after their last infusion on either the first or second Friday, they will then have some follow-up integration sessions to bring it together and try to solidify not just, okay, I got these infusions, but how am I as a client feeling that I've now built my own new fishing rod and I've been practicing using it. I feel what that feels like. I trust that structure and I feel comfortable implementing it moving forwards. And with that, it's called a stabilization protocol, that first 1 or 2 weeks. That's all the heavy lifting. It's still likely beneficial for a client at varying intervals to possibly come and have a booster infusion or a maintenance visit. It may or may not. Sometimes we experience full remission. Sometimes we're just experiencing significant benefit. It's all about embracing the fact that we're all a work in progress. And that as we continue that journey of implementation and real life, it's very helpful to have support, not just psychologically, but also neurologically, to try to reinforce periodically what is the path that we're building here. That's just a form of self-care that a client chooses to or not to utilize whatever they feel is appropriate for them. I don't tell people what to do because it varies significantly, right? I've got people that maybe come back once a year. Occasionally, I've got people that come back once every 2 months or something like that. The goal is always, however, to eventually move towards them feeling totally self-sufficient and independent, right? The goal isn't to try to incentivize a revolving door of need, but we absolutely must support that person. And that will be different for everyone as they're continuing that healing journey.
And can anybody come from anywhere to
Anywhere. We have people that come from the local LA area. We have people that come from out of state. We have people that come internationally. And for those that are traveling from distance, what we'll do is we'll work with that client to try to help them arrange a location to reside that is close to us, that they're able to get transport to and from the clinic. But what we recommend to people is they don't come alone, right? It is an intense process, and we don't want people feeling like they're having to figure everything out for themselves about every meal and how to get to and from. So having someone that they know and trust to be able to allow them the bandwidth, the liberty, and the wherewithal to invest only in their program, right? And not trying to figure out Los Angeles and facilitating things. That's something we need each client to figure out and have that person with them here. Obviously, that's a lot easier if they're local in the Los Angeles or greater area. But even if they're, not, and if they're coming from a distance, that's still very important.
I was curious of that too, because for me, it would be all the way on the other side of the country.
And that's not uncommon, right? It's all about just, we help people organize that and try to make things possible for each person, including financially, right? This is not an inexpensive process. And I wish, that we had insurance companies on board, but no insurance companies will pre-authorize ketamine infusion for any indication yet, whether that's for depression, anxiety, PTSD, OCD, chronic pain, CRPS, or even substance or alcohol abuse recovery, which we have some of the most cutting edge programs in the world here for those reasons, and the ability to reset central reward instincts that have been desensitized from drug or alcohol abuse, as well as a truly holistic recovery process utilizing cutting edge technology and science combined with that integrative, okay, now what? And to be able to build that in a relatively short period of time.
Okay. I wanted to ask too, it's hard to, I don't know if you could recommend anything with how unique your program is. If somebody didn't have the ability to get to you, is there anything that you would tell them to look out for if they were to try and seek something like this in their area? I'm sure there's plenty of definitely not going to help you places versus might a little bit. I'm not sure if that's even a answerable
I think
question.
it's a reasonable question. Absolutely. And I'm happy, like I said, just to be a resource or to be able to provide information to assist people, whether they're working with us or on a journey somewhere else. Information is power and comfort. I don't know of any place that has all this comprehensive approach in one place. But if we're just talking about the ketamine, because that's mostly what you're going to see out there, right? One, it has to be an infusion.
Okay.
No oral or intramuscular or intranasal is going to help with this. And there
Okay.
are neurophysiologic and structural reasons for that. That's possibly a separate conversation where we can go into
Yeah.
detail and I can explain those things. But it has to be an infusion. It cannot be less than a 2-hour infusion, but it should be 4. If it is CRPS and it is a central sensitization situation, it should be 4-hour infusions.
Okay.
And it needs to be at least 5 consecutively, Monday through Friday.
Okay.
Okay.
Mhm.
And they should be aggressively trying to up titrate the dose over the course of that week, right?
Right.
So
You did
the
the
amount total that you're getting on Friday should be probably 4 times higher than that which you got on Monday.
okay.
And if possible, finding a place that actually does adjust the infusion midstream. Not they give you a bunch of ketamine and then you come in the next day or whenever they have you coming in and they go, so how was your last one? And they might tweak a little bit here or there, but not significantly. These are really important opportunities and we want to get everything we can out of it. To be honest, I don't think there are many places that know how to do that. But if you are able to ask those questions, then possibly if there is someone there that at least can do that, then maybe you'll be asking them to do that for you, even if that's not what they normally do for most people.
And it's comforting to know this what to for people to know what to ask, because I think sometimes we don't know what really is the most important part of the details of the situation.
Mhm.
And I
If the other thing I would say is this should still be an integrated process, right? If we just go and we go, okay, as long as I get some ketamine in my body, then all the stars will align and that'll be all I need forever to fully recover from my CRPS, whatever caused it and whatever patterns are progressing it. I don't think that's a realistic expectation. I think that we need to address either with your own therapist or maybe an integration coach that you hire separately. And I do know some companies that could be able to provide those services for people outside of the clinic that they're getting the ketamine from, right? So you might be able to actually build sort of your own process. It just
think
wouldn't be centralized under one roof where we're able to optimize all the angles around that one person.
that would make sense, though, if you couldn't do that, to optimize as best you can
Mhm.
to find it in each place. You build your own team of people, like you said, in your own process.
Exactly.
And I would like to eventually go into that of having it be an infusion, not orally, and how the body breaks it down each
Mhm.
way. I think that I just learned that you could take it other than an infusion not that long ago, and I didn't know that was an option. So I'm curious to see
The
how that.
problem is that ketamine right now is a fad. And so there's a lot of companies, clinics, and providers that are trying to jump on the bandwagon and they're offering that which gives them the best profit model or what their license allows them to do. And it can be quite misleading as to the fact that's not the same. And for really clear scientific reasons, it's not to say there might not be some value for some purposes, right? Such as with a person like a psychotherapist who's trained and experienced in, let's say ketamine assisted psychotherapy, right? They might take an oral or intramuscular dose, and then as that is playing out in terms of its experience and how the physiologic metabolism and experience of that can be predicted, they're working with their client to work in different psychological components into that experience, but it's purely for psychological or psychotherapy plus, right? It's not going to induce neuroplasticity. It's not
Right.
going to change the infrastructure. It's for a pure psychotherapy plus approach. And I think that can be of value for some people in the right experienced hands. And even with that, there's a lot of folks that are, I can do ketamine assisted psychotherapy, but all they're really doing is they're just sitting there and holding space and comforting the patient without really doing much. And the reasons to do it, those other modalities, there may be reasons to do it, but it won't help for pain and it won't create the ability to change long-term patterns, instincts, things like that, which requires sustained depth of experience, which doesn't occur with the other delivery mechanisms. To overcome that inherent resistance that we
Right.
know is built in, to be able to actually convince our neuropsyche that, oh, we're serious. We really want you to remodel and repattern after these new signals that we're showing you. That's another conversation we can have. But yes, infusions for pain, for non-central pain, 2 hours is sufficient, not 1 hour. A lot of places will say, oh, yeah, we give our little 40-minute infusions that we give for everything under the sun. And then the website will go, ketamine has been shown to provide relief for the following conditions. Yes, that is a true statement. But that 40-minute infusion has not been shown to provide relief for a lot of the conditions that are listed on that
Right.
menu, right? And so when it comes to pain, it should be a minimum of a 2 hour infusion. And if it's central sensitization, CRPS, RSD, centralized severe migraine syndrome, things like this, it really should be a 4 hour infusion protocol.
Okay. It's good to know then. Now we have a baseline for anybody that can't. And I believe a lot of this is on your website. When I was reading,
Absolutely everything that I've said, more or less, is on our website. It's probably the most in-depth from a scientific as well as a holistic understanding of how this tool should be used in an integrative way to really change things for whatever it is we're trying to change. And on each page of the conditions we treat, there's multiple sections. It goes into the neurology and the receptors and understanding the process and the program and the components. At the bottom of each page, there's a section called customized protocols for individual clients. And it goes through for, let's say, depression, anxiety, PTSD. We have a 1 and a 2 hour protocol. It explains why and what are the things to look for as a client to determine maybe whether I could consider one or the other. And then for pain, there's the same section and it talks about the 2 and the 4 hour protocol and the differences between them and why we believe certain people need to strongly consider a 4 versus a 2 if the shoe fits. And whatever a client chooses to do, we're going to support them 100%, right? It's not like we force people to do X, Y, or Z. There's no real downside. Having some treatment's better than no treatment. But I think that it's our ethical responsibility to educate and help people make informed decisions so that they're empowered in their own journey.
I can't thank you enough for taking the time out of your day to sit with me and go so in depth with everything. So I have a full understanding and we can share it with others and hopefully get them to be able to have access to treatment that will actually help them long term.
It has been an absolute pleasure, Brittany. Thank you for this opportunity and thank you for the work that you're doing. There's a lot of people out there in need, and I think you're doing something similar to myself. We're experiencing the sublimating reward from helping other people in areas that we're personally familiar with. And it's us embracing our own journey as we're helping others in theirs. And I give you great credit for having the courage to do that.
It's nice to know that people out there like you have a patient's back and will dedicate their life to finding something